Good morning. I am Majestic Radiance Mapute, and I am a second-year medical student. May I know your name and your birthday, please?
Good morning, Doc. I am Nelger Macabulos. I was born on April 25, 1994.
So today, I'm going to check your anterior and posterior chest, and I just would like to inform you that we are going to take off your shirt. Would that be okay with you?
Okay, Doc.
Okay. So this would take for about 10 minutes, and this would include inspection, palpation, percussion, and auscultation using stethoscope at the end of this. Would that be okay with you?
Okay, Doc.
So let's start with inspecting the posterior chest of our patient. So as I inspect, I have seen dark spots in the patient's posterior chest, and it's because of his childhood history of burns. Other than that, there is no deformities or any asymmetric chest expansion in our patient's chest. Second, there is also no muscle retraction that is usually found here in the lower rib cage. Third, there is no impaired respiratory movement as our patient breathes. So, muscle retraction are usually found in patients with COPD and asthma, and asymmetric chest expansion are usually found in patients with pleural effusion. Next is palpation. When you palpate the posterior chest of our patient, focus on the areas of tenderness, bruising, and fremitus. So when palpating, we need to test chest expansion of our patient. I will put my thumbs in the level of his 10th rib and my hands on his lateral rib cage. Inhale, exhale. Inhale, exhale. So when I test the chest expansion of my patient, my thumbs move together symmetrically and normally. So now we're going to palpate both lungs for tactile fremitus. To detect the fremitus of my patient's lungs, I will put the bony surface of my hands and put into his lungs. Will you please say 99?
99, 99, 99, 99, 99, 99,
Again.
99.
So in every palpation that I did, I felt the vibrations on my hands. So now we'll go to percussion. Percussion helps us know if the patient's lungs has fluid, air, or consolidated. Consolidated in cases like lobar pneumonia or pleural effusion. For better palpation, it's best if we stand beside our patient, and me, as a right-handed person, I will use my left middle finger as my pleximeter finger and my right middle finger as my flexor finger. See to it that when you press the surface of the patient's lungs, do not let the other fingers touch the surface so that it will not dampen out the vibration. Sir Nell, I'm gonna start tapping your back. So as you observe, when I tap the posterior chest of my patient, resonance sound is replaced with dullness sound. Especially when you go down, resonance sound is already replaced with dullness sound. Dullness can be heard usually at the lower part where your diaphragm is and where your liver is located. Let's now do auscultation, but first, can I ask you to cough first, sir? Okay, thank you. So I let my patient cough first because it would produce an important sound as we do the auscultation later. And I also let him undress because clothing can alter the characteristic of breath sounds. So same with percussion, we will do auscultation through ladder-like manner. So please breathe deeply with your mouth open. Exhale. Please say 99.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Please say E. 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 Please whisper 99. 99. Now we'll do the same with the anterior chest of our patient. So let's start with inspection. Again, there is no any deformities found in our patient's chest. There is also no muscle retractions which are visible, especially in his costal margin. And lastly, the breathing of our patient is normal and no respiratory or impaired respiratory movements. Now we'll do again the palpation by putting my thumbs and my hands on the lateral rib cage. Inhale, exhale, inhale, exhale. So let's palpate for the tactile fremitus. Please say 99.
99, 99, 99, 99, 99, 99.
Okay. Now we'll do the auscultation. So please take a deeper breath. So that's the end of our examination. Thank you, Mr. Neil, for your cooperation.
Welcome daw.
Till next time. So here is the result of Mr. Neil's chest anteriorly and posteriorly. During palpation, I felt the vibration every time I tapped the chest surface and of course, no unilateral decrease of fremitus in any of his chest. And during percussion, when I tap from top to bottom, from resonant it becomes dull as it goes at the level of the diaphragm, which is also normal. Dullness is best heard where liver is located. And lastly, in auscultation, I haven't heard abnormal breath sounds and no adventitious sounds such as crackles or wheezing like in cases with asthma and COPD. The overall result of the examination of Mr. Neil's chest is just normal.